The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Now, before we get started, I'll introduce our speaker. Vicki Kobliner is a registered dietitian who has extensive experience using various diet modalities to help children with autism and related disorders. Vicki works with infants, children, and adults with chronic illness, digestive disorders, food allergies, ADHD, and autism, and provides fertility and prenatal nutrition counseling. You can type your questions into the questions section now and throughout the talk. She'll answer as many as she can at the end. And now I'll turn it over to Vicki.
Thanks so much, Denise, and I'm happy to be here. Welcome, everybody, and thank you for joining me today. As Denise said, I have worked with kids on the spectrum with neurodevelopmental delays and other chronic illnesses for quite some time. And one of my particular passions that has emerged over the course of these years is really trying to understand how we can stop or halt the progression of chronic disease in our babies. And that comes with both prenatal care, pregnancy care, as well as first year of life care. And as we have lived through the COVID-19 pandemic, it became increasingly of concern to me that we don't know what the outcomes are for babies that were born during this time or for women who become pregnant during COVID-19, and what does that mean? And I'm going to preface all of this by saying we really still don't know much, but I'm going to tell you what we do know, and I'm going to tell you what we can learn and what we want to investigate going forward. So this is my disclaimer, and I'm sure you can all understand this. Any information that is in this presentation should not be considered medical advice. We all know that for good advice, you need to go to a practitioner that knows you and your story more intimately. Personal recommendations for pregnancy planning should be discussed with your healthcare provider always. And information about COVID-19 is constantly evolving and subject to change. I'm reading articles daily with new information that's emerging about ways to treat, ways to address, possible risk factors, etc. So we want to stay current with those. Whatever I say today will probably be slightly modified a week or two from now. So we want to be current on this. In addition, always remember that the best thing you can do is to follow proper procedures for hand washing, social distancing, masking, and surface cleaning to help you to avoid getting infected. And I will also tell you that while we are certainly seeing many, many different levels of infection throughout the country, I personally am living in the Northeast, and we have been suffering tremendously, both with the healthcare system, and the loss of life has been quite tragic. I do personally know multiple people who have gotten COVID, some who have not survived. So I do want us all to be able to take this seriously and be wise about the choices we make. So one of the things I'd like to point out is some underlying principles about pregnancy and childbirth in general and how they relate to COVID-19. So the World Health Organization has a standard. I used a number of their graphics because I really like them. But basically, their philosophy and their statement is that before, during, and after childbirth, all women have the right to high-quality care. And this includes antenatal and intrapartum. We call antenatal is what we call prenatal, newborn care, postnatal care, as well as mental health care throughout the cycle of conception, pregnancy, and baby's first year of life. And in COVID-19 times, these requirements or these rights are equally as important. However, there are concerns about COVID-19 and how do we integrate and provide women with that care and have them be, those rights still available to them when we know that there are risks that are involved. So some of the things we have to take into consideration are, what are the effects of COVID-19 on moms? So how does having a pregnancy and if you are infected with COVID-19, not only affect the fetus, but affect you as a pregnant woman? What are the increased risks to mom? And what are those risks as they pertain to both the pregnancy process as well as labor, delivery, and birthing process? Because there are different risks that are involved there, such as, do you have a C-section? Should you not have a C-section? What would be the deciding factors around that? What about isolation? Should mom and baby be isolated from each other to prevent baby from being exposed to the disease if mom is infected? What types of medications are being used and how might they affect mom? What are the mobility limitations? And when we talk about that, we know that for any of us who may have had a child in the past, we know that very often what you want to do is walk. While you're waiting to deliver, while you're in the first stage of labor, you're going to be walking the halls or walking up and down. Well, at this point, most women are not allowed to walk the halls anymore if they are considered either infected or have a fever and, you know, there is a suspicion of COVID. They're being told they need to stay in their room. So how do we deal with helping you have that baby when your mobility is limited? In addition, there are questions about birth partner, companions, doulas, et cetera. Who is allowed in the delivery room with you, and what is each hospital's unique perspective on that? Another great concern is that of people of color. We know that African Americans are suffering more serious outcomes when they contract COVID. We know that very often because of just endemic medical racism, if we want to call it that basically people of color are not always treated with the same respect in the hospital. And we need to make sure women of color really need to make sure that they advocate for themselves and they're very clear about what their rights are so they can protect themselves. In addition, the other question becomes, what is the mom's carrier status? And then finally, worker safety, because again, as you are delivering, you are exhaling very intensely, and all those aerosolized particles are going into the air. And so how do the people that are helping you give birth protect themselves? So let's start from the beginning. You're pregnant. How can you protect yourself against COVID-19? Well, again, the most basic concepts will remain true. Try not to get infected by keeping clean. Wash your hands frequently. Put space between yourself and others. Avoid touching your eyes, nose, and mouth. And cough or sneeze to your belt, elbow, or a tissue. And I put that little picture of a mask in there because that wasn't included in the World Health Organization guidelines, but absolutely masking should be used and is helpful. So if you have fever, cough, difficulty breathing, seek care early. Call beforehand, follow medical advice. So again, what a lot of physicians have moved to and continue to move to is a telehealth model, even for pregnant women. So many of the prenatal visits can be done by telemedicine. If you have a fever, cough, or difficulty breathing, you should absolutely call your provider and make sure that they're aware of it and follow their instructions. So aside from those non-pharmaceutical or non-biochemical interventions, what we also want to talk about are what are the foundational interventions any woman can use to support her health and her safety during and pre-pregnancy. So good nutrition, you can only imagine I'm a registered dietitian. Good nutrition to me is the foundation of good health. You want to be making sure you are including all those high antioxidant foods, lots of good fiber, which helps you detox. You want to make sure you're using things that are rich in all the nutrients like zinc and vitamin C and vitamin D that are antiviral and have immune boosting properties. You want to make sure you're not eating things like lots of sugar. I know it's hard, we're all stuck at home and a lot of us are not eating the way we would ideally, but sugar is an immune system depleter. And at this time, it's one of the things you do not necessarily want to be doing. In terms of physical activity, again, while maintaining appropriate social distance, physical activity is always helpful for boosting immune function, as well as just keeping your overall health status optimized. Adequate sleep is absolutely essential. Again, stress really impairs immune function. Lack of sleep reduces your ability to withstand and be resilient in the face of stress. So we want to make sure that sleep is happening as best it can. And then avoiding alcohol and drugs, obviously. And again, avoiding alcohol and drugs, we are seeing a tremendous increase in alcohol intake as people are quarantining at home. So if you are pregnant, you obviously want to think long and hard about how much alcohol you may be drinking and avoiding as much as possible. So let's talk a little bit about what the studies tell us. And before we do, I do want to offer these caveats. We have very little information. If you Google COVID, you're going to find thousands of research articles right now. If you Google COVID in pregnancy, you will still find hundreds. But hundreds are still not that many, and most of them in their sample size, the sample size may be 3 people or 5 people or up to 100 people, but really not much more than that. So these are very, very small studies. There is no control group. We can't compare it to somebody, who was selected as an equal comparable person who didn't have COVID-19, for example, because we're only dealing with what we're exposed to right now. We also have really at this point only third trimester information, because obviously the women who were delivering in January, February, March were women who were in their third trimester. Now in April and May, we are starting to see outcomes of women who were in their second trimester, when they may, but if they contracted COVID now, they still may have contracted COVID in their third trimester, but we do have some data about women who contracted it in their second trimester. But we don't really know anything about first trimester, and we know very little about second trimester. And finally, the adverse effects and outcomes that occurred, that were consistent with COVID and infection may not actually be related to the virus, but may have been something related to an underlying risk problem to begin with. So what we know about pregnancy and risk to mom in general are that pregnancy automatically predisposes women to respiratory and viral infections because their immune system becomes suppressed because you don't want to reject your own baby. So the immune system is automatically suppressed and viral and respiratory infections are more likely. We also know that there are changes in the cardiovascular and respiratory systems related to pregnancy. Now, one of the fears initially about SARS-CoV, which is COVID-19, is CoV-2, is that SARS-CoV and MERS, Middle Eastern Respiratory Syndrome, both of those, the outcomes for pregnant women were much worse than the regular population. So when we first saw women having babies who had been infected with COVID, there was a great fear about what those outcomes would be. As it turns out, what we're seeing is not the same as with those other diseases, and most of the outcomes are quite good. So that's really positive. But initially, there was great fear around what might happen to pregnant women and their babies if they contracted COVID-19. Remember, as I said before, adverse outcomes may not be due to COVID-19, but to the underlying health risk factors that increase their risk of getting COVID-19 to begin with. So here's a study, and this one I consider actually it's kind of old. It's already a month and a half old. In COVID-19 days, that's like a dog's life. It's 7 years. So we know that early data from an analysis, again, of 41 pregnant women, this is not tremendous amounts of people, but it's what we have available to us, showed that they had higher risks of miscarriage, preterm birth, preeclampsia, cesarean delivery, particularly if they had been hospitalized with pneumonia. Their babies were at higher risk of stillbirth, but this is a very, very tiny risk. So bear in mind, it is not happening with regularity. Neonatal death, tiny, tiny risk, and admission to intensive care unit, which does happen at a slightly higher level than it does in the general population, but it's still not happening abundantly. So mom goes to the hospital. She is pregnant. She finds that she has contracted COVID-19. What are her rights in the hospital? We want to think about that because your rights may be different depending on the hospital where you are having your baby, or the birthing center, whatever place it may be that you choose to have your baby. There are many different rules in many different states and different cities and many different hospitals. So you want to know those rules, and this is another layer of information that we didn't used to have to do when we would, do our birth plan. But for now, you really want a COVID-19 birth plan. So as the World Health Organization states, women are entitled to respect and dignity during childbirth. There should be clear communication by the staff. They should be entitled to a companion of choice. They should be given pain relief strategies, and they should be allowed mobility in labor where possible and the birth position of choice. These are all things that you should think about for yourself. What do you think your birth position might be? How much mobility might you want? Who might you want as your companion in the delivery room? What kind of pain relief are you considering? And have knowledge of those things and have a discussion about those things before you end up in the delivery room, because you will be much better able to advocate yourself during that time. And the birth companion of choice is an important piece because there are many women who, number one, want to bring their spouse, their partner, their child's father, whoever that may be, or they might want to bring a doula with them. And very briefly, some private, in New York City at least, private hospitals at the beginning of onset of COVID-19 were they were barring anybody but the laboring woman in the delivery room. New York finally overturned that order and insisted that everybody be allowed to bring at least generally it's one partner into the delivery room. But if you need to know your hospital's policy on that, because I know, New York State, I know Connecticut, but I don't know the policy in every state or every city. You need to know the hospital's policy for who you can bring with you and what you have to do to make sure that that happens. But essentially, in most cases, if anybody is allowed in, it's one or the other and generally not both. So if you are using a doula, your partner may not be allowed in. If you want your partner, your doula may not be allowed in. So if you are utilizing somebody like a doula, you should know this in advance. One of the other things that was happening with regularity early on, and now fortunately has become much less of a problem, is that pregnant women who were, entered the hospital to deliver with COVID-19 were routinely automatically given a C-section. The reason for that was that it was felt that you wanted to get the baby out as fast as possible to avoid any kind of what we call vertical transmission, which means transition from mom to baby in utero. But it also meant that you spent less time in the delivery room breathing in and out with a group of healthcare workers with you, and so you were not spreading the virus that way. Again, in retrospect, what we've realized is vertical transmission is very, very rare, if at all, and that there are ways to protect ourselves so that women should be, again, allowed to deliver vaginally whenever possible. As you know, and again, in discussion with your healthcare provider, you decide whether you want a C-section or vaginal delivery, and you have the right to ask for vaginal delivery, even if somebody tells you they think you should have a C-section just because of COVID. Now, if you have other health risks, if you have individual reasons why a C-section would be appropriate for you, again, that is something you should discuss with your healthcare provider. But COVID-19 alone is not a justification for a C-section. The next phase of this whole process is once you have given birth to the baby, what happens to the baby? This is all about what's happening in the hospital experience. So once you've given birth, again, in the initial phases, babies were immediately whisked away from their mothers, put into isolation, and moms kept in isolation. So there was no breastfeeding. There was no skin-to-skin contact. There was no communication, no bonding of mom and baby in order to prevent the baby from getting COVID-19 from an infected mother. Those opinions and those policies have changed because what we're finding is that vertical transmission is not particularly common. There's a few outlier cases where it seems like it may have happened, but it also may have been caused by something else. So right now, the general consensus is vertical transmission doesn't really happen. And again, that vertical transmission means from mom to baby in utero. So there is less of a fear about that. And in terms of the breathing and the aerosolized particles, as long as healthcare workers are wearing protective equipment, they should be able to let a woman labor properly and let her bond with her baby once she has given birth. So, according to the CDC, isolation, the determination of whether or not to separate a mother with known or suspected COVID-19 in her infant should be made on a case-by-case basis using shared decision-making between the mother and the teen. You as the mother, or if there are dads listening, you have the right to have that conversation with your healthcare provider. There is no automatic assumption that your child needs to be removed from you. You should, considerations include, how is the mom? And now again, you can have a mom who has COVID-19 positive, but who is essentially as healthy as any other woman in terms of symptoms. You can have another woman who's having trouble breathing and needs to be on a respirator, and that's going to be a completely different situation. So mom's condition very much dictates and informs what you do about isolation. You also want to know if mom is positive, and if the infant is positive, that negates the need to separate the two because the baby's already positive. Does mom want to breastfeed? If so, there's going to be skin-to-skin contact there. There's going to be communication and contact, so isolation does not make sense. And again, what is the facility's capacity to even accommodate a separation like that? And can you maintain it after discharge? Because if you have a child who gets discharged from the hospital in 24 hours and they're going to be right back with that person who you were trying to isolate them from, it doesn't make a lot of sense to isolate them when in that first 24 hours you could be giving them colostrum and breastfeeding and skin-to-skin contact, etc. So these are the things that you want to think about if you go to the hospital and you find out that you are testing positive. Now, there are concerns about COVID-19 and the outcomes for the baby. So one of the things we do know is that there is a higher incidence of preterm birth, as well as other complications. So with that in mind, we want to do everything we can to make sure mom is healthy in advance and be mindful of, again, avoiding infection, but also knowing that it is a possibility. Delayed cord clamping is another issue. Now, that is something that is recommended because once you give birth, as soon as you cut the cord, baby is reliant upon itself for all of its oxygen needs. If you wait to clamp the cord 30 seconds, 60 seconds, there are some hospitals that do it up to a few minutes. But if you wait to clamp the cord, then the baby actually gets more oxygen. And there are some studies that show that that's beneficial. But again, around COVID-19, basically the concept was, let's get that baby out as quick as possible. Let's get the baby separated from mom as quick as possible. Let's move this process along. There is no evidence that that is necessary. So if somebody desires delayed cord clamping, it's still something that a parent can ask for. Vertical transmission, as we talked about, we're not seeing a lot of that. We are seeing horizontal transmission, and I'll talk more about that later, but we're also seeing that most babies actually recover quite well. So that's very positive. We also want to talk about the opportunities for breastfeeding. And as I mentioned, another concern for babies that we still don't know a whole lot about is what might impact baby's health with an infection in first, second, or third trimester, and we don't know. So this is just an article, and again, there are many out there, but this one was the relationship between status at presentation and outcomes among pregnant women who had COVID-19. So what we were seeing is that they studied 55 women, 33 were symptomatic for COVID-19, 22 were not. 48% of the women who were symptomatic were delivered by a C-section versus 27% of women who were not. That's a pretty big difference. And again, this did not review whether it was the mother's choice or it was a medical need or whether it was just something that was initiated by the hospital. But this is almost 50% cesarean delivery is quite a lot. We also saw a higher incidence of preterm birth. And less than 37 weeks was 27.3%, but less than 34 weeks, which is much more, serious and has more complications for the infant, was almost 10%. Oops, sorry. Go back there. Preeclampsia, slightly elevated as well. And then we see that 12 women out of the 33 required respiratory support versus none of those who were asymptomatic. And 16 of them received medication. And the length of hospital stay was an additional day on average. So there is an impact physically on moms who have COVID-19. You want to, again, stay as healthy as possible so you can avoid it, and also know what your risks might be so you can advocate for yourself as you are delivering. Now, one of the things that has come up, and I just actually added this, I've done this lecture a number of times, and I just added these slides 2 days ago as new information has emerged. One of the things people may be hearing is that initially we were looking at this really as a solely respiratory disease, and that was the predominance of the complications. But now we know that hemorrhaging and clotting and, clotting is another big problem. Thrombotic events are a big problem for many people who have COVID-19. And from the study of some placentas, it has become obvious that the placentas are being affected by SARS-CoV-2. There are more clots, they are smaller in size, they are less oxygenated, all of which can potentially be problematic. So again, the placenta is an amazing thing, and even when your placenta is not 100% functioning, even a small percentage, a percentage of your placenta needs to function in order for the baby to get everything it needs. But even if part of it is not, a baby can be born very healthy. But some of the things we see with these placentas in COVID-19 positive mothers were that they had an increased rate of preterm birth delivery. They had a higher expression of certain proteins that are required for SARS-CoV to enter the cell. We've seen more of this in maternal feeder tissue. Out of this study that I just mentioned, 6 placentas delivered by 5 women with COVID were investigated. 3 of those 6 placentas showed changes consistent with inflammation and vascular abnormalities with thrombohemorrhagic alterations. So basically what that means is more risk of clotting, more risk of bleeding, more risk of, and again, smaller placentas as well. We have no idea, again, what that means for a baby. And we have no idea what it means for a baby whose mom might have been infected first, second, or third trimester. Theoretically, one might assume that a baby who is infected, or the mom is infected in the first trimester, when the placenta is, when everything is smaller and the the baby is at an earlier stage of fetal development, it may be more problematic. We don't know. And we don't know what this means when the baby is a child or an adult. We don't know what it'll mean for development. All we know is that we see this placenta change, but that most of the babies that were born from moms who had COVID-19 seem to be doing fine right now. So again, I don't want to make anybody more fearful than they should be. I just want them to be aware. I want you all to know how important it is to stay healthy and think about your options. This is a study, it was a case series from a large New York obstetrical practice. And I just wanted to point this out because, again, when we think about what are the risks and how scary this all sounds, we see that predominantly the outcomes are pretty good. This was 757 women. 92 of them had known or suspected COVID-19. Out of that 92, 33 were positive on test. Only one of those women required hospital admission for 5 days due to COVID-19. One other woman received home oxygen. None of them required mechanical ventilation. There were no maternal deaths. There was one unexplained fetal demise at 14 weeks, but again, we don't know if that was related to COVID or it might have been just coincidental. And then out of the 20 of these 92 women who had delivered, all of those deliveries were uncomplicated. So if we go back up to here, this was a different study. This showed different outcomes. These look slightly worse. The case series from this obstetrical practice was actually very positive. So for the most part, we can assume that outcomes will be positive, but we want to be as wise as we can in terms of making sure that we do everything to stack the deck in our favor. So a couple of other concerns to think about are carrier status. So just because you don't have symptoms doesn't mean you're not a carrier. It doesn't guarantee no infection. You can also have a negative test and be positive shortly thereafter, or so you can't assume that you don't have it. You want to in some ways act as if, just in case, especially if you are ready, getting towards your delivery date. You want to have this plan in place, even if you don't think you have COVID. Because if you go to the hospital and you have a fever and they test you and you have COVID-19, things are going to change, and you want to have thought about those decisions beforehand. Women of color, as I mentioned, have a much increased risk for complications, both due to medical inequality and greater average risk of health factors. So women of color should be extra careful and extra mindful. And then again, we talked about the worker safety with chronic, heavy exhalation during labor. But that is another thing I want to mention. There are some hospitals who had originally considered trying to quicken the second stage of labor. The second stage of labor is when you are actively breathing and trying to deliver. During that phase, there were hospitals that were trying to shorten that phase so that less people were exposed to the exhalations. That is not generally being done in most hospitals anymore, but if somebody recommends it, that's another thing that could certainly require some pushback. Now, after baby's born, these are the things that may impact their development, their future development, and all of us who are, affiliated with ARI kind of know what when we're talking about these things, we know what we're worried about. So C-section, higher increased incidence of C-sections with moms giving birth who have COVID-19. Breastfeeding versus formula. If babies are being taken away from mothers and mothers are being told they can't breastfeed, that's an issue. And just so we know, there is no evidence of transmission through breast milk, none. And the breast milk has been tested, in multiple studies. There is no evidence that you can pass COVID-19 through breast milk. Now, obviously, you could pass it if your baby is breastfeeding, they're not 6 feet away from you, then clearly you may pass it through your respiratory secretions. So you do have to be careful, but breast milk itself is not a source of COVID-19 infection. Maternal immune activation and fever are two things we know have been correlated with increases in developmental delays. So if mom is sick, has fever, etc., that's going to place baby at higher risk for developmental delays. In addition, acetaminophen. So again, we know that NSAIDs were originally not to be used. The recommendations, there was fear that NSAIDs would actually activate something called the ACE2 receptors. We know now that that does not seem to be a problem, but NSAIDs themselves are not recommended in pregnancy. They are contraindicated. So if a mom has a fever, we are in many ways between a rock and a hard place. So staying healthy is the first choice. Tepid baths are also super important, and doing anything you can to keep yourself healthy and the fever minimal. Antibiotics being given is another issue that we know, can affect babies and their microbiome. So we want to be careful about that, because we see a lot of the use of azithromycin with COVID-19. So we want to be careful about the antibiotics. And then again, the incidence of preterm birth being higher is linked to onset of, an increased risk of developmental delay. So I think many of us know this aspect of some of the correlations and some of the linkages between autism, neurodevelopmental delays, chronic illnesses, and some of these birth and infant outcomes. So we know that C-section has been associated with an increased risk of autism in multiple studies. So if we have a C-section, we really have to, again, really drill deep into building that baby's microbiome early on. And part of that is going to be breast milk. Part of that is probably going to be giving probiotics, but lots of things we can do to help baby develop a healthy microbiome. But we need to be mindful, if the C-section happens, that we need to be extra careful and extra forceful about building a good microbiome. So as to breastfeeding, I've obviously mentioned this a number of times, but breastfeeding is super important for normal health. It supports babies' underlying immune system. It provides immune modulation when baby's immune system is not yet completely developed, supplies antibodies, and also supplies something called human milk oligosaccharides. Now, human milk oligosaccharides I find them fascinating. They're actually a compound in breast milk that has no understood or identified health benefit to humans at all, and yet it is a very large part of breast milk composition. What we do know about HMOs is that they feed good bacteria. So again, this is an incredible way the human body acts in symbiosis with those gut bugs that we so need. And by breastfeeding, the baby ingests the human milk oligosaccharides, which then go feed the good bacteria in the intestinal tract and help the baby colonize a healthy microbiome. So when you do not breastfeed, or if you have COVID-19 and somebody advises you not to breastfeed because you could infect your baby, you have to think about the benefit of immune tolerance and immune function that comes from the breast milk itself, the human milk oligosaccharides, the healthy microbiome, as opposed to contracting COVID-19. We know that children who breastfeed longer than 6 months have better cognitive outcomes, lower risks of developing ADHD, and lower risk of being diagnosed with autism. So again, there's a lot of the immune, gut, neurologic linkage here that would only be exacerbated, in my mind, when mom has an infection, baby is born to an infected mother, and then doesn't get some of this support. So I always say breastfeeding is a very personal and individual choice. Each person should do what they think best. But if you want to breastfeed and you are told not to because of COVID-19, that is something that you can push back. So the World Health Organization, again, their statement and their position on breastfeeding is that close contact and early exclusive breastfeeding helps the baby thrive, and even a woman with COVID-19 should be supported to breastfeed safely, hold her newborn skin to skin, and share a room with her baby. So rooming in is another thing that is often not an opportunity that's not offered to moms if they're COVID-19 positive. So if you want your baby rooming in, that's an option you have. Now, if you are going to breastfeed, you must be careful. It's not a risk-free proposition. Women who breastfeed should be wearing a mask when they breastfeed. They should practice excellent hygiene, washing their hands before they touch the baby, making sure they don't touch their face, making sure that everything is fully cleaned, and routinely cleaning and disinfecting all surfaces that the baby comes in contact with and they come in contact with before they touch the baby. But wearing a mask is also very important. Now, the other option, there are women who may decide that they are too scared, they don't want to breastfeed, and they don't want to have that contact, but they want their baby to have access to the benefits of their breast milk. So clearly, expressing breast milk is an option. And if a woman is either too physically ill or just too nervous to breastfeed, she can provide her breast milk in other ways. Expressing is obviously the easiest. Relactation is another option, and what that is basically when you induce lactation after a period where you haven't breastfed, and then also donor human milk. But I think for most women, expressing their breast milk can be a very good, viable possibility if they are nervous about having the baby in a lot of contact with them. In terms of breastfeeding, the CDC's position is as follows: that any infant being breastfed by a mom who's confirmed to have COVID-19 should be considered as having COVID-19 or suspected 19 for the purposes of infection control. That makes total sense. It's obvious. We would assume that the baby might have it. They should be sent home. They should be isolated. They should not be going out in the community during that time. And mothers should be counseled to inform their child's healthcare provider that their child has this high-risk content. So this is basically the CDC position, is similar to just sound logic. If you have COVID-19, if you can assume your baby may have COVID-19 too, and you should both stay home and be quarantined. So that's logic, but nobody is saying that the two of you should be separated or isolated. Now, with one of the other risk factors for neurodevelopmental delays is maternal immune activation, which is essentially moms getting infected and having their immune system activated by some sort of trigger. And again, what we know, this is a study from 2017, was that pregnant women who got infected with flu virus had increased risk for complications, including preterm labor, preterm delivery, and birth defects. We don't know if it's the flu itself that caused it, but we know that we see in animal models that when women become infected and have increased immune activation, you can also see a higher risk of developmental delays. So, and birth, preterm birth and delivery. So we want to be careful. Again, the bottom line here is we got to stay as healthy as we can, not take risks that are going to allow us to get infected, and try to be as cautious as possible. Again, one more study, this one from 2019, long-term risk of neuropsychiatric disease after exposure to infection in utero. Fetal exposure to a maternal infection while hospitalized increased the risk for autism and depression. These results emphasize the importance of avoiding infections during pregnancy. Now again, women have been getting fevers and infections when they're pregnant through, evolution. Some of us will get sick. It is not uncommon for a woman to get sick. I don't want to put fear in you, but I want you to be wise and I want you to be informed and do everything you can possibly do to support your own natural health status. Again, prenatal exposure to fever associated with autism spectrum disorders in a Boston birth cohort. So reinforcing the same thing. Now again, I mentioned acetaminophen and NSAIDs. Early reports basically postulated that NSAIDs might worsen the course of COVID. We have found that that is not true. So this has not been substantiated. The World Health Organization rescinded their commentary about dangers of NSAIDs, but NSAIDs are contraindicated in pregnancy. So it is not I know that many of us are fearful of Tylenol, fearful of acetaminophen, but NSAIDs are contraindicated in pregnancy. So you have to be very careful about that. Here's another article about cord plasma biomarkers of acetaminophen exposure and the risk of autism and attention deficit disorder. So the healthier we be, the less we have fevers, the better off we're going to be. So let's talk briefly about prevention. NPI, non-pharmaceutical interventions, clean hands, avoiding close contact, covering your nose and mouth, cleaning and disinfecting frequently, and avoiding touching your face. These are still some of the very best things you can do to maintain your health and avoid infection. I'm going to talk a little bit briefly now about some herbs and other things that we might want to use to support ourselves, but we have to remember, COVID-19 is new. We know information about herbs that can be supportive in colds and mild flu, but they are, number one, not necessarily adequate for severe infections or their complications, and we have no proof as of yet that any of these are specifically preventive or protective against COVID-19. So what we do know is that there are certain nutrients that are, number one, very safe in pregnancy, and number two, very good as natural immune support and antivirals. Vitamin C, zinc, and probiotics are three of those. So yeah, I would be recommending that unless it's contraindicated, and again, this is not medical advice, this is not individual advice, but as a general rule, I think most women could do very well with vitamin C, zinc, and probiotics. In addition, we know that vitamin D is likely safe. There were some initial concerns about its role in ACE2 and allowing the virus to enter through those receptors, which was the ACE2 receptor is the way that COVID-19 is getting access to the cells. So, and vitamin D can support ACE2. So there was some concern that it would actually increase infectivity. But what we're seeing is that that's not the case, and that serum ACE2 is not problematic. It's a cellular level, and the vitamin D is not increasing that. So vitamin D is likely very safe, and I would recommend it in most cases. Now, elderberry, there was a lot of talk about fears of elderberry because it can upregulate immune function and cause a cytokine storm. So the information on that is really very suspect. Anybody who's in the process, anybody who's at risk of a cytokine storm should be doing a heck of a lot more than elderberry by that point. But the truth is, elderberry is not approved for pregnancy. So regardless of whether you would be using it for another reason, I believe elderberry might be very safe for COVID. But if you are pregnant, you shouldn't be using it anyway. The other thing that's gotten some traction in terms as a strong and potent and wonderful antiviral, which I use regularly in many people, is vitamin A. Vitamin A is a wonderful antiviral. However, there is evidence that high doses of vitamin A can be teratogenic during pregnancy. Teratogenic means that it will cause birth defects. So vitamin A is not something that anybody should take in high doses if they are pregnant. That's a no-no. So let's talk a little more about vitamin D, because I know that there was a lot of information out there that was confusing. So I just want to have a little bit more focus on that. So we know that vitamin D supplementation can reduce the risk of preterm birth and low birth weight. We know there's plenty of studies that show that it is associated with reduced risk of respiratory tract infections and flu. So again, we're trying to avoid that fever. We're trying to avoid that maternal immune activation. Vitamin D is a terrific thing you can use. Also, there are numbers of studies that show that vitamin E in higher than typical doses can be protective against neurodevelopmental delays. Supplementation of vitamin D improved outcomes in ventilator-dependent ICU patients. Its respiratory role is important. It can increase hemoglobin and bring oxygen to the cells, and it may reduce the risk for cytokine storm. So for all these reasons, again, not an individual recommendation, but in general, I do believe vitamin D can be very helpful and very appropriate during this time. In terms of herbs and supplements and their relationship to pregnancy, we know that ginger, garlic, and nettle, all three of these are potent immune supports, that we know that they're safe for pregnancy, but we have no information that directly links them or their role or protection against COVID-19. So for general immune support, eat lots of ginger, eat lots of garlic, enjoy it. Nettle tea can also be super nice. So you might want to incorporate those things into your day. I wouldn't necessarily take them as a therapeutic supplement, but I would incorporate them into your diet and into your life. In terms of melatonin and quercetin, these are getting a lot of press. They are showing good outcomes and good effects on COVID-19. However, there is insufficient evidence for safety during pregnancy. So I don't recommend these as a matter of routine, but I will tell you that melatonin has been tested safely on pregnant women. So I am more comfortable with the use of melatonin. Quercetin we know less about. We know a lot about it in regard to its immune boosting properties. We don't know as much about it in regard to pregnancy itself. And two herbs that have been in the literature regarding their potential use against COVID-19 are andrographis and licorice. Those must be avoided by pregnant women. Both of those can induce miscarriage. So you want to be very careful about the herbs and supplements you choose and what you're reading, because what may help for COVID-19 in general will not necessarily be safe for a woman in pregnancy. So another thing I wanted to mention, and this is also somewhat newer information, but there is a compound called a specialized pro-resolving mediator, SPMs. They are derivatives of omega-3 fatty acids, but they are kind of drilled down derivatives of it. We know that they downregulate inflammatory immune responses. We know that omega-3s are safe in pregnancy. And we are also seeing some evidence that SPMs may have the potential to reduce inflammatory responses in COVID-19. So there is the possibility and interest in the use of specialized pro-resolving mediators for COVID. Again, SPMs specifically have not been used in pregnancy. Omega-3s are. So I feel like the safety of the SPMs is probably pretty good. But again, I could not outright recommend something like an SPM because we just simply don't have enough data. And I don't think this is the time to be taking a chance on something like that. Postnatally, what can we do if we know that we have had COVID-19 and we've given birth to a baby? We want to breastfeed when possible, if that's something we're interested in doing. We do want to add omega-3s, those essential fatty acids, so we can produce those SPMs. We want to make sure we're using probiotics so we can support that baby's microbiome. The vitamin D, all can be given to the baby. And mom can continue to take things like ginger, garlic, echinacea, vitamin C, zinc. All of these are considered safe while breastfeeding. So these are the ways you can make your immune system and the baby's immune system more robust, more resilient, and help them with their development. So in summary, what we know about COVID-19 and pregnancy is extremely limited and remains so, and it continues to change. What we also know is that pregnant women should focus not on what to do if they get COVID, but on how to not get COVID, optimizing prevention as their first line of defense. Don't assume you're not a carrier. If you're infected, use safe immune support strategies. Know your birthing options before you get to the hospital, because you may not think you have COVID-19, but it may turn out that you do. So understand those birthing and delivery options, individualize them, and communicate your desires to your team, and make sure the people that you are relying upon to help you deliver that baby know what your intentions and your desires are. And again, mindfully provide your baby with immune and neurodevelopmental support, and monitor their milestones, especially in that first year of life, because we want to be cautious that if there is a possibility that these children are at higher risk for neurodevelopmental delays, we want to notice that as possible. And with that, I just wanted to give you this last study. If anyone is pregnant, University of California, San Francisco has started a registry, a nationwide registry for pregnant women. And if you would go there and fill out the information, you may be able to be part of a study, and it would obviously help everyone to know more about this disease. So with that, I want to thank everyone. I will certainly take questions. I see a couple.
Yes, and I've got some here too, Vicki, that I can read to you.
Okay, great.
Okay.
Well, I see one. Well, thank you for saying it was useful. Will it be shared with the participants? I will absolutely give Denise the slides, and she can share them.
Great, and I can post those afterwards. We'll send out the link with the PDF.
Great.
So one question that I got, this is sort of a thoughtful question, so I don't want to put you on the spot too much about history, but they're asking, in thinking back on historical parallels of past pandemics, are you aware of any trends or outcomes in terms of babies from the swine flu or other pandemics that have occurred that might have similarities to this?
That is a good question, and I have to go look at it more. I think one of, with a lot of those other pandemics, people weren't tracking, in the same way, but I think one of the issues was that there was so much concern about what was going to happen to the woman and the baby during the pregnancy process. I don't think people have really done a targeted study of long-term outcomes of kids who were born, who from infected mothers. It's more always been about what happens during the time of delivery. Is there more miscarriage? Is there more preterm birth? Is there more, stillbirth, et cetera? And it's been more about the delivery process and the birth process, as opposed to 5 years out, what do those kids look like? But I think that I'm going to have to go look at that. That's very interesting. Thank you.
I got another question about, seeking a clinician or practitioner who would be knowledgeable, about both of these things, sort of with the immunological awareness, but also who works in pregnancy and birth. If you were pregnant right now, how would you put your team together?
That is a darn good question.
Yep.
And, it's funny because when this first started happening, I started reaching out to a lot of my contacts and said, I'm really worried about this. I just think, everything we're hearing about COVID and how it's being treated and what people are doing, the C-section, initially the C-section, the no breastfeeding, the isolation, I was like, this is a, problem waiting to happen. And as I reached out, people were not jumping on the bandwagon the way I expected them to, so to speak, to want to find more knowledge. I'm the only person I know right now who's actually doing these kinds of lectures or trying to figure this out in this way with the autism neurodevelopmental delay focus. I would love to get in touch with more people. There are some pediatricians. I think the interesting thing is there's more pediatricians who seem to care. The comment, Dr. Harrell, this is Song, like those pediatricians who are already involved in the neurodevelopmental delay space are more interested in this concept and emerge. But in terms of obstetrician gynecologists, I don't know too many. My instinct would be to go to something like IFM and see somebody who's just an integrative obstetrician in general and start talking to them and having this conversation with them about what they think. But there is no one person or registry of people that has been identified as of yet who's pursuing this.
Okay, this question is about after baby goes home, and I know you touched on this, so I wonder if you could repeat it. The recommendations, it sounds like, are just 14 days, just like if you had traveled or anything else. If you were bringing home a baby next week, if you're pregnant and coming home next week with your baby, how would you approach that as a new mom?
I would be doing exactly what I did with a typical baby. I mean, the bottom line is what we're seeing is that most babies that are even those that are born, and I should probably specify more about the vertical and horizontal. There are quite a number of babies that seem to contract COVID-19 from their mother in the first day or so of life, who are then testing positive, but it wasn't an in utero infection. So we know that babies are getting it, but most of them are recovering fairly well. So I think you need to do what you would normally do. I think you need to do everything to boost their immune system, including breastfeeding, making sure they're getting their good probiotics, making sure they're getting their omega-3, their vitamin D, making sure you as mom are getting your vitamin C, your zinc, etc. Doing all that stuff to make sure the immune system is as robust as possible, making sure things are clean, not exposing them to other people. But mostly, I think if you follow standard habits, then the baby's is going to be, the likelihood is that baby will be fine. But make sure you are distancing, make sure you are quarantined, make sure you're not exposing this baby to infections. And also, check if the temperature seems to be elevated, be more mindful, be more quick to call the pediatrician if they seem to have a fever, things like that. But there is not a lot that I would do differently, except for the things I mentioned, which are all about immune support.
Well, it sort of sounds like what you're saying is just pretend, even if it's not your first baby, pretend it's your first baby.
Yep. That's a good way to look at it, right?
Right,
yeah.
Because most of us with our first baby are much more heightened. I mean, I know I was that way with my first son, and then with my second son, not to say I was negligent, but I was probably less on guard all the time about germs and hand washing. So
correct. So I think that's a good, Denise. Thank you. Yes, make believe it's your first baby again, and be as mindful about hygiene practices as you can.
Right. Now, I know we don't know much yet, and you touched on this a little, but the post-corona period, I know we're seeing that pediatric syndrome come up in kids, and I've had a couple questions about what do you do, say the baby was born, the baby was positive, but baby's okay now, it's been about 45 days. Any insight on that, or is it just too soon to know where that's going?
It's too soon to know. There was, Dr. Harron and Dr. Wells just did a talk on that post-infectious syndrome yesterday. The kids who seem to be the most afflicted are older. They're not infants. We're seeing kids more in I forget the actual age range, but it's, early teen, late, like 7 to.
Yeah, I think I've seen it. It's tweens, like 8 to 14 or, yeah.
It's in that range.
Right.
So I've seen a lot that says that infants are getting this syndrome. We want to, again, you have to be mindful of it. And that's what I said, when you said, what would you do? Be more mindful. If you see something that, it's the old, if you see something, say something. In this case, if you're worried about something, act more aggressively than you might if it was, your typical kid that you didn't, that was just you just brought your baby home and they had not been exposed to an infection. I think if you see the extremities turning blue, if you see some of those mottled rashes, like know the signs of what that post-infectious syndrome is and be mindful of it. Maybe post a list somewhere, but really what we're seeing is that most of the kids that are getting it are much older.
Right. So trying to be watchful, but maybe not worry too much unless there's
Correct.
some kind of evidence, but then acting quickly.
Correct. I think that's about all of it is know the signs, know the risks, be prepared to act if you need to, but don't assume it's going to happen.
Okay. Well, so how about, I got a question from a parent who said her child is healthy now, but he's 6 weeks old, and she said, kids get regular sniffles too. I'm confused about when to go to the doctor. That's she's wondering if during this time. I know there's a lot in the news about people sort of skipping appointments at this point. I'm not asking you to give medical advice, but should parents be not shy about still calling the pediatrician and going in if they feel like they need to?
I think they should be not shy about calling the pediatrician. I think they should be shy about going in to expose their child to unnecessary germs. So if you're worried, if the child is sniffling, if you think they have a fever, absolutely call the pediatrician. Absolutely. But I would not bundle my kid up and rush them off to the doctor before I had a conversation first about what's happening in the community, who's going to be there at the doctor's office, and what else might be going on.
Okay. So just taking advantage perhaps of telehealth when it's available. I know a lot of physicians are hoping to do that when it's appropriate. So yeah. Being comfortable with that. I know for a lot of us as parents, that's a new experience to have your doctor say, hey, let's do this, over the computer.
I have to tell you, I'm doing nothing but telehealth for the past 2 months, and I love it. I feel like in many cases I've actually gotten up. Number one, I can see the family's home. So I see what's going on. They can grab their supplements and bring them and show them to me. Hold them right up in front of my face. They can show me some food. You can get really close up to the family. I feel like in many ways it's almost more personal because we're face to face in a different way. So I wouldn't necessarily want to be solely telehealth, but I think there are a lot of advantages. And again, we need to use telehealth to our advantage when we can, and then when it's not appropriate, face to face is certainly excellent.